would like to talk about a different topic now about graft manipulation and following immunotherapy. So these data I would like to present you are based on pediatric patients. However, these results can be easily transferred also to the adult world. So what is the idea and the strategy of graft manipulation? Instead of utilizing whole bone marrow or leukapheresis, which definitely needs a pharmacological post-transplant immune suppression, we want to prepare grafts with a defined composition of cells, with high numbers of CD34 positive stem cells, with reduced numbers of alloreactive T cells in order to avoid GvHD, with enough numbers of antigen-specific T cells, maybe against viral antigens, with reduced numbers of B cells to avoid EBV-associated lymphoproliferative disease, and with high numbers of potentially anti-leukemic effector cells like NK cells and gamma delta T cells, which do not cause graft versus host disease. So graft manipulation in matched unrelated donors can really minimize the rate of GvHD. In mismatched donors, it is a precondition to avoid lethal GvHD and to reduce the risk of EBV-LBT. In both, it is possible to avoid long-lasting pharmacological immune suppression post-transplant, which offers a basis for early starting further immune therapy after transplantation. So these are the principal methods for graft manipulation. First principle is to isolate only the pure stem cells, which is about 1% of the graft, and to discard all other cell types. This is the so-called positive selection. Second principle is to discard only the unwanted cells, and these are T and B cells, or only T, alpha, beta, and B cells, and to use all the remaining cells, CD34 plus NK cells, plus gamma delta C cells, and so on. And this is the so-called negative depletion, which will be used at the moment. So we have established the MAX method for this purpose. Cells of the leukapheresis product are incubated with magnetic beads coated with antibody. Then the cell suspension runs through a strong magnetic field. Conjugated cells are retained into the field, and all other cells run through. And since the microbeads have only a size of 50 nanometers, you cannot see them in the microscope. These are CD34 selected stem cells. However, electron microscopy reveals these very small spots on the cell surface. For this depletion process, we use a semi-automated device, the Clinimax device, in our GMP facility. And this is the evolution of the graft manipulation methods, and I now want to focus on mismatched haploidentical transplantation because this is the major indication for those graft manipulation procedures. We started in 1995 with the CD34 positive selection, and we infused pure stem cells and nothing else. Then we switched to the CD3, CD19 depletion, the T and B cell depletion, and these grafts contain stem cells and effector cells, mainly NK cells. And at the moment we evaluate the T cell receptor alpha beta CD19 depletion. Here the grafts contain stem cells and a combination of effector cells, NK cells, and gamma delta T cells. And additionally, we are able to produce antigen-specific T cells, by example, against viral antigens if necessary. So when do we use a full haplotype-related donor? In all patients who need a transplantation but lack an identical donor, if there is no HLA identical sibling, if there is no sufficiently HLA-matched unrelated donor, and we accept only a 9 or 10 out of 10, donor if we have not enough time to wait for donor search or for special indications. Now I would like to show you very briefly our results with the CD34 positive selection method. Again, we infused pure stem cells without any pharmacological GVHD prophylaxis after transplantation, and all donors were full haplotype mismatched parents because I talk about pediatric patients. So this is the graft composition. We infused a high number of stem cells with very low numbers of residual T cells, only 10,000 per kg body weight, which means a 4.5 log reduction of the T cell count of the graft, and with only less than 10,000 residual B cells and no other additional cells. With this approach, it was possible to reduce the GVHD rate to an absolute minimum. You can see less than 10% and almost no severe GVHD, which was significantly lower than that of a control group, patients who had matched unrelated donors and who had received unmanipulated bone marrow. However, the incidence of lethal viral infections increased because of the delayed immune recovery post-transplant, and we mainly had to fight against adenovirus and cytomegalovirus. This is the outcome. Our biggest patient group are patients with ALL, and we could find a nice survival of about 45%. So the positive selection results so far are it is still a reliable standard method. In our experience, we found a 45% EFS for pediatric patients. However, in need of improvement was the T cell recovery and the rate of viral infections and also the transplant-related mortality. So we switched to our second model, the CD3, CD19 depletion. Here we infuse stem cells and some effector cells. Again, this is the graft composition. We infused again a high number of stem cells, 16 million, was now less than 50,000 per kg body weight T cells, which means a 3.9 log reduction of the T cell count. And we infused additionally high numbers of NK cells, about 100 million per kg body weight. And this is the conditioning regimen. We started with ATG at a very early time point in order not to harm the co-transfused NK cells at day 0. And this is the chemotherapy backbone. It consists of fludarabine, thiothepa, and melphalan. Here you can see the kinetics of ATG. Indeed, with this strategy, we had a nice peak at day -8. So we have a rejection prophylaxis during the conditioning regimen, but no further in vivo depletion at day 0 because we end up with very low levels, and we don't need a in vivo depletion here because we do an ex vivo depletion. We want to save the NK cells, which we co-transfuse, thus ATG levels must be low at that time point. The engraftment was very fast, with 12 days to reach more than 20,000 platelets and 10 days to reach 500 neutrophils. Interestingly, the recovery of platelets was even faster than after the positive selection procedure. Probably, we could not prove that, probably due to the presence of megakaryocytic progenitors in those grafts. And this is to show you that also the immune recovery could be improved. This is the number of CD4 at day 90 after transplantation, after CD34 selection, and after the new selection procedure. This is the cumulative incidence of GVHD, which was still very low. We had 16% grade 2 and only 6% severe GVHD with this approach. And this is the immune recovery post-transplant, as you can see, NK cells already raise up within 14 days after transplantation and reach a high peak. Afterwards, they go down to normal levels. CD19 positive B cells start at day 30 to recover. The T cell recovery is slower because of the profound depletion. However, we find about 200 CD3 positive cells at day 100, and patients needed about 1 year to reach completely normal T cell levels. This is a comparison of the transplant-related mortality between positive selection and CD3, CD19 depletion, and we found a significant reduction of the TRM, probably due to the better immune recovery. This is the event-free survival of all patients, with various diagnoses, I have to say. Here you can see the EFS of our biggest patient group, patients with ALL in any complete remission, with again about 45%. Patients with non-malignant diseases did well. You see here patients with immune deficiencies and storage diseases and patients with aplastic anemias. However, the relapse rate after CD19 depletion was still unacceptably high in patients who did not reach a remission prior to transplantation. So patients with active disease at time of transplantation still remain an unsolved problem, whereas patients who achieved any remission prior to transplant had an acceptable relapse rate. Thus, we switched to the third approach, which is currently under investigation now in a multi-center clinical trial. Now we infuse, we do a alpha-beta, T-cell receptor alpha-beta in CD19 depletion. Thus, we infuse NK cells and also gamma-delta T cells. Again, the backbone is a high number of stem cells with low numbers of residual alpha-beta T cells, less than 18,000 per kg, and with high numbers of NK cells and also gamma-delta T cells. And this is the strategy for this depletion procedure. It consists of 2 steps. First, cells are incubated with the alpha-beta biotin-related antibody, and second, antibiotin and CD19-coded microbeads are added. So we only lose alpha-beta and CD19 positive cells, and we preserve all our cell types in the graft. And this is the efficacy of the procedure. We ended up with a 4.75 depletion of alpha-beta T cells and a 3.4 log depletion of B cells. Here you can see a typical flow cytometry analysis prior and post-depletion. Alpha-beta T cells are completely depleted, whereas gamma-delta T cells are retained into the graft. And this is to show you that the procedure is very reliable without any outliers and with very low variances. 30 patients have been transplanted in this multi-center trial, most patients with ALL and myeloid leukemias. 44% of these patients already had received a second or even third transplantation prior to this protocol. All donors were full haplotype mismatched donors. And this is the current treatment scheme. It is very similar to that I showed you before. Our aim in this trial was to give at least 4 million stem cells with less than 25,000 alpha-beta T cells. And we introduced a short single-agent immune suppression with mofetil mycophenolate until day 30. The zero therapy consisted of ATG again. In the first 12 patients, we infused 15 milligram per kg body weight, which was lower than usual. However, the incidence of rejection increased, and we then had to switch to 30 milligram per kg body weight in the following 16 patients. And as an alternative, total nodal irradiation can be also given instead of serotherapy. So again, the engraftment was very fast, like in CD3, CD19 depletion with 12 and 15 days. And a final engraftment could be achieved in 29 out of 30 patients because one patient died due to TRM before he could be transplanted. An initial engraftment occurred in 23 patients because the ATG doses was too low in the first 12 patients. However, after a reconditioning regimen and a second stem cell donation, all rejectors could be rescued. And this is the incidence of acute GVHD, which was extremely low, with only one patient developing GVHD grade 2 and without any severe GVHD. The immune reconstitution was assessed centralized in order to get robust data, and here you can see the CD3 recovery. We ended up with 150 CD3 cells already at day 14 and with about 260 at day 100. Interestingly, gamma delta T cells were the predominant CD3 positive population in the very early post-transplant time phase and preceded the recovery of alpha beta T cells. Later on, there was a switch, and alpha beta T cells represented the majority of T cells as usual. This is the reactivation rate of adenovirus, cytomegalovirus, and EBV. The most frequent reactivation was adenovirus in stool, which is a typical problem in pediatric patients. However, the frequency of reactivation in blood was lower because of the preemptive therapy. In contrast, CMV was no big problem. As you can see, less than 20% reactivation, and this reactivation rate was similar for all three compartments, urine, blood, and throat. And no EBV reactivation occurred at all, probably due to the profound depletion of B cells. Now, this is a comparison between the recovery of CD3 cells after CD34 selection, the old one, and after alpha-beta depletion. And as you can see, there was a significant improvement for alpha-beta depletion compared to CD34 selection. This was also true for day 90. Afterwards, there was no significant difference anymore. So what can we do in case of a resistant viral infection if this infection does not respond to antivirals, ADV, CMV, or EBV? In that case, we are able to isolate specific T cells from the donor. We need about 500 ml donor blood or an unstimulated leukapheresis. We do an ex vivo stimulation with the corresponding antigen overnight, and specific T cells can be recognized by their gamma interferon production afterwards. So these gamma interferon positive cells then can be isolated with the gamma interferon secretion assay, and we end up with a mixture of CD8 and CD4 positive T cells, low numbers, about only 5,000 per kg body weight, which is almost nothing. And these cells can be directly infused into the patient. Here you can see the adoptive transfer of antigen-specific T cells for CMV as an example. These patients had no detectable antigen-specific T cells prior to adoptive transfer. After adoptive transfer, almost all patients showed an in vivo expansion of this very low amount of specific T cells. And exactly these patients were able to reduce their viral load or to become completely negative for CMV. If there is no in vivo expansion, we could not find clinical effect. So what can we do after transplantation if we have succeeded with the transplantation? We want to give a very early starting immunotherapy after that. I would like to show you first a compassionate use program with an anti-CD19 antibody in B lineage ALL, which is a very good indication for immunotherapy at the moment. One option for immunotherapy is to increase the NK activity which are already present with ADCC, with antibody-dependent cellular cytotoxicity. Sometimes NK cells are inhibited via K receptors if the target cell expresses cognate HLA alleles. However, if it is possible to stain the target cell with a specific antibody, by example, against the CD19 antigen or against the GD2 antigen in pediatric neuroblastoma, the NK cell can bind to the Fc part via its Fc receptor, and this inhibition will be overcome. So we produced an ADCC-optimized anti-CD19 antibody in-house within the university. 2 amino acids were exchanged. So this antibody construct does not activate complement. It has no direct cytotoxicity like rituximab, and therefore it has only very mild side effects. Here you can see NK cell mediated effects of the antibody. This is the parental non-ADCC optimized antibody, and this is the ADCC. With this Fc optimized antibody, you can see there is a significant increase of cell lysis, of tumor cell lysis, and the same is true for stimulation assays. TNF-alpha, interferon gamma are very positive with this special antibody construct. And also gamma delta T cells can mediate ADCC. You can see here the specific lysis without antibody, and this lysis with the Fc optimized antibody, again a significant increase of lysis. So we have administered these antibodies in 26 patients. Up to now, all patients had CD19 positive high-risk ALLs, which were primary refractory to standard treatment. These patients had a first or even second relapse after previous transplantations. 9 patients had received the first, and 17 patients had received even a second or third transplantation before giving this antibody. So the indication was prophylactic use if no MRD was detectable, or infuse or therapeutic use if MRD was detectable. Our proposed duration at the moment is 24 months. We think we have to give this non-toxic antibody for a very long time, and we do it at the moment every 2 weeks at a 3-hour infusion on an outpatient basis. And this are the results of the prophylactic use. The black line represents all patients. The blue line represents patients who received the first transplantation, or the second line represents patients who received a second or even higher transplantation. And these are the results in case of detectable MRD. You can see that we were able to reduce the MRD load in 11 out of 14 patients for at least 1 log. This is the MRD load prior to antibody infusion, and this is the MRD load after antibody infusion. And here you can see the overall the event-free survival in these patients. Please remind, most of them had even received a second or third transplantation, so these are really extremely high-risk patients. Okay, the second option of an antibody-based immunotherapy after transplantation is blinatumomab. You all are familiar with this antibody construct. It is a B-specific antibody with a specificity against the CD3 antigen on T cells and against the CD19 antigen on tumor cells. So this antibody construct needs T cells as effector cells. No NK cells, only T cells. And we have established a compassionate use program. We have treated 9 patients at extremely high risk. This is the status prior to blinatumomab therapy. The patients had a first or up to 4th relapse, and all patients had even at least 1 transplantation or even a 3rd previous transplantation. And this is the response to blinatumomab. Indeed, 6 out of 9 patients showed a complete remission, whereas 3 out of 9 did not. So 5 patients could proceed to a subsequent stem cell transplantation. Well, this is the outcome in detail. We infused between 5 and 15 microgram per square meter per day, and the patients received between 1 and 4 cycles. As you can see, 5 out of the patients became MRD negative despite this extremely high risk population, and 1 patient could reduce at least his leukemic load. This is an interesting observation. In 2 patients, we found a secondary response after additional chemotherapy. Both patients first did not respond to blinatumomab. As you can see here, the blast load could not be reduced. Thus, we decided to stop the blinatumomab infusion, and we gave another chemotherapy at that time. So the chemotherapy, of course, could not cure the patients, but it could reduce the blast load at least for some time. And afterwards, we started again with the blinatumomab cycles, and with this reduced blast load, it was possible to achieve a complete MRD negativity. So the question was, is there a correlation between the number of effector cells and response? You can see here the course of T cell counts during blinatumomab therapy. Normally, we observe a strong T cell proliferation a few days after start of blinatumomab therapy, and within this T cell proliferation, the MRD goes down. And indeed, the ratio between CD3 cells and CD19 positive blasts was lower in patients who did not respond than in patients who responded. Thus, the responders had rather high numbers of T cells and rather low numbers of blasts. And this is the event-free survival of all patients. This is the EFS of responding patients, whereas non-responders, of course, could not be rescued. And this is an interesting option to increase the blinatumomab efficacy. You can see here the surface PD-L1 expression on patient blasts who did not respond and on patient blasts who did respond. And we could show that ALL blasts from non-responding patients had a higher expression of PD-1 ligand than that of patients who responded. Also, in cytotoxicity experiments, we could show that the cytotoxicity could be increased when adding PD-1, by example, pembrolizumab antibody, to the blinatumomab approach. So we think the use of PD-1 antibodies is reasonable and should increase the lysis of targets with blinatumomab. So this would be another option for the future. So my conclusions are, graft manipulation allows to produce very individually designed transplants with defined numbers of T cells, complete T cell depletion or sometimes T cell reduction. You can effectively reduce GVHD. You can add antigen-specific T cells. And we have no long-lasting post-transplant immune suppression, which allows us to use, by example, antibody-based immunotherapy very early after transplantation. So finally, I want to thank all my colleagues, and I want to thank you for your kind attention.